The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. This is Gary Swartz, Associate Executive Director of the American Academy of Home Care Medicine. Thank you for joining this afternoon. What we want to provide is an overview of Protecting Access to Medicare Access Act and an introduction to risk-adjusted HCC payments. Topics to be covered today: the provisions of the Protecting Access to Medicare Act, updates on codes and services under development for 2015, provide an introduction to risk-adjusted payment, ICD-9 coding, and HCC scoring, reference the annual meeting and Academy resources, and take questions. As you know, about a month ago, the Protecting Access to Medicare Act passed, and this was House Resolution 4302 that was signed into law. The two key items we want to focus on this afternoon is that Medicare payments would remain at current levels from April of this year through the end of March of 2015. So the SGR cuts were averted for this year. That also means that during the fall and early of next year, we're likely to have the activity to avert the SGR reductions once again on the way to a permanent fix and Medicare payment reform. Also, the legislation included that implementation of ICD-10 diagnostic coding set would be delayed a year, at least until October 1 of 2015. The payment, the SGR payment fix, this is the provisions that provided for the payment fix, and that an update factor from April of this year through through the end of this year and into March of next year would be 0%, so that payment levels remain as they are. We have the payment levels at the national level posted on the Academy site if you ever need to reference those for the house calls and certain research codes, transition care management, etc. Those remain as they are. And then, again, Section B says that, again, that we have to do things over again, and that the update or keeping things as they are ends at the end of March of next year. The delay of ICD-9 remains in effect, and that's actually for an indefinite period of time. CMS said they would put out an interpretation to stakeholders, while many organizations, including your own, were probably well on their way to getting organized and planning and implementing the changes necessary for ICD-10. The sense was that, and evidence was that there was a lack of readiness. And so Congress has instructed CMS to delay implementation of ICD-10 through at least October of 2015. And so ICD-9 remains important, and even more so as payment systems evolve that take into consideration diagnostic coding. This is reflected in changing CMS policies that are oriented to paying services at the level that is paid at the lowest cost of care of any site to support primary care, seen in a shift from volume to value payments and towards accountability and outcomes. Related to that is CMS activity on codes and services under development for 2015. Many of you have also participated in surveys with the Academy to support these activities. First one is the Chronic Care Management Service. This would be a G code in CMS parlance for next year, and standards are to be developed this year for coverage and payment effective 2015. As we speak this afternoon, there's an AMA CPT meeting occurring now, and this code is under review. Similarly, there was an effort of the AMA CPT group to develop a code to have you paid for services that are rendered around advanced care planning and that are not adequately reflected in the current payments for evaluation and management services. Related to the chronic care management service, the first item, CMS is developing standards that practices would have to meet in order to be paid for the chronic care management services. And the Academy is working on its own and with other groups to make these standards attainable and relevant for your patients and for your practices. Along those lines, the Academy does have a standards development process underway to develop standards for house call practices that public and private payers and other third parties would view in terms of practice certification. And these would be used to provide a standard of practice and also to inform the CMS development of standards, and to have the CMS and others adopt and look toward those that the Academy would provide as the acceptable criteria. There is an evolution of payment systems that is occurring, and again, that was also focused moving from CPT payment and procedural payment to value and also population health management. This slide reflects that evolution, and this is also taken from an article that appeared this week from JAMA Online. One of the important items beyond the content of this article is that it was written by CMS officials. And we see that the beginning is that there was a fee-for-service payments with no link to quality. As things evolved, there became a link to quality. And some of you are reporting measures that CMS has developed over time in an effort to reflect quality and quality measures and process. There is the move towards alternative payment models built on a fee-for-service architecture, and this would be included IH and ACOs and the patient-centered medical home, and then a movement towards towards population-based payment. And again, these also emphasize the role of diagnostic coding. This next slide describes that move from CPT to diagnostic-based payment, where we were in a traditional fee-for-service-based payment environment, and that we're moving and evolving toward a payment environment that is moving towards the condition of your patients and towards population health management. And that those codes, the chronic care management codes and the standards development, also reflects this movement. Since this is going on and ICD-9 remains in place for an indefinite period of time, we wanted to provide an introduction and overview, if you will, to ICD-9 coding and to HCC scoring, provide a definition for risk adjustment, describe HCC, provide a reference to how CMS audits HCC documentation and coding, provide some references to ICD-9 guidelines and resources, point you to references where the HCC codes are and ICD-9 mapping so that you know what in terminology risk adjusts and what codes do not risk adjust, and then provide some documentation recommendations. Why do HCC scores matter? As we've seen, HCC scores matter because we have this evolution of payment systems occurring, and with the Medicare, well, not on the slides, while the Medicare fee schedule is essentially frozen, you're going to want to develop opportunities that may be based on the diagnostic condition of your patient population, coding, and the HCCs. And we are hearing from practices that there is that interest, both from the practices presenting that opportunity to payers and also payers seeking out practices to develop those opportunities to manage their high-cost patients as identified through diagnostic coding and HCC scoring. HCC scores matter because they provide support for clinical management, patient risk stratification, efforts at outreach into certain populations and certain individual patients, and identification of the right interventions to provide to those patients. And it also provides comparisons across clinicians, practices, and populations. From a financial risk management perspective, HCC scoring provides metrics for reporting and feedback and review of the practice and from third parties. It provides an opportunity for reconciliation and adjustment of payments and relationships with third-party payers and even within practices and within organizations such as ACOs. And it provides information that supports negotiation with existing payers and for new payers. And again, our members and perhaps some of you on this call this afternoon are providing us information that this is indeed occurring in the marketplace across private health plans with a variety of populations that they are taking care of. So what is risk adjustment? Risk adjustment is an actuarial tool used to predict healthcare costs based on the relative actuarial risk of enrollees in a population or in a plan. And so again, this is an insurance-based terminology to understand what future health costs may be based on information that we have today, and that that information is based on the diagnostic conditions of the patients. The risk adjustment process involves the risk assessment, again, of each individual in the group or a population or a health plan or in the practice. And again, this reflects the predicted overall medical dollars that are expected relative to the claim dollars for an average risk person. And then the second step is to modify that risk assessment to reflect differences in risks for individuals in the population, and referred to as a risk adjuster. So how's the risk adjustment process used in Medicare? The Balanced Budget Act of 1997 mandated that Medicare payment to Medicare Advantage plans be based on risk adjustment. In 2002, the HCC, or hierarchical condition category, payment model was adopted to accomplish that risk adjustment as to the extent that it explains the variance and has a predictive power for future health costs, medical costs to the program, and that's why that model was adopted. Legislation required full implementation by the late 2000s, 2008, and coding, diagnostic coding that supports the HCC scoring methodology and Medicare payment to Medicare Advantage plans can come from inpatient sources, outpatient sources, and also from physician sources that includes by Medicare definition, nurse practitioners, physician assistants, et cetera. And physician, and the importance for Academy members and to Medicare is that physician coding is the main source of the diagnostic data that drives the payment model and the HCC scoring. The references here are to backgrounds. The second one is a summary of the HCC model that was adopted, and the top reference there in orange is to a more comprehensive analysis of the HCC model that was adopted by Medicare. So how does the model work? It is currently in place. It uses ICD-9 codes, the thousands, and it funnels those into what will be in place for 2014 into 79 codes, or HCCs, each with assigned scores and disease interactions. That is done through a hierarchy for disease groups, where payments provided for the most severe manifestation of a disease, even if a less severe manifestation of the disease is also present. and sicker participants, more complex participants or beneficiaries with more diagnosis may trigger more HCCs. HCCs are additive for a patient, and then the HCC model is recalibrated periodically using more recent cost data to Medicare, and there is a 2014 versions going into effect and posted on the CMS site, and we'll provide you that information. Again, this provides kind of the flow of how it starts with the ICD-9 codes, moves across to what's called qualifying codes, and with the final result of the HCC codes, or the ones that are scored and then subsequently weighted for payment, a much more limited group. Certain of the ICD-9 codes risk adjust or make themselves over to the or under consideration to feed into the pipeline of the 79, and other codes do not risk adjust. This goes to specificity. That specificity is based on the ICD-9 coding guidelines, and again, we'll provide you that information over the next slides. This chart slide provides you some examples of low specificity coding and whether that would have been included in the risk-adjusted models or HCC scoring for 2013, or for 20, and if so, in any value or weight in 2014. And you can see the low specificity diagnostic coding on the left, and you see that few of those make themselves into, get risk adjusted, if you will, in the column for 2013 risk. Drilling down following the coding, ICD-9 coding guidelines, we see that more refined diagnostic and more specific to that particular patient diagnostic coding results and is documented, and then we see what the 2013 risk would have been and the 2014 risk. And you can see that with higher specificity of the diagnostic coding, that codes just using that did not appear in 2013 version would have with more specific diagnostic coding, and that would be appropriate coding driven by the guidelines. And then 2014 column also reflects that there is adjustment to the HCC models that CMS has in place, again referencing the periodic updates, and you can see how the weights attributed to those specific diagnostic codes have changed from year to year. So what does this mean? And again, this is an explanation or a predictor of medical expense in the future as related to an average. And so with an average risk score of 1 based on diagnostic coding, this was a historical payment level of the $7,463. So a patient with more conditions, more condition interaction occurring with a risk score of 1.5 would have higher costs, with the $7,463 average multiplied by that 1.5, and so that patient would be considered more expensive than average. Office-based patients could be considered around a risk score of 1, and we see in IAH and similar populations that there are HCC scores 3 and above. And then on the other hand, a risk score that would be below 1 would mean that there'd be expected cost below the average of the $7,463. And again, the patients that you are seeing, the importance to Academy members, those of you on the call, is that your patients are presenting, you're treating patients with such a multitude of chronic conditions and diagnostic coding that you're treating and documenting, that the risk scores would be high, and then this also results in how the payment system for health plans and for other plan methodologies is evolving. There are other components to developing the risk score before it gets multiplied by a dollar figure, and those components include a demographic component that contributes to the risk score, and some of those elements are listed here, and also what's termed a frailty factor that also contributes to the HCC scoring. And this also goes to the importance of documentation and picking up the ADLs of your and dependencies of your patient population. So as mentioned, kind of working from the bottom of this slide up, the total risk score is the HCC score driven by the ICD-9 diagnostic coding. The frailty adjuster is applicable, and the demographic characteristics, and then for Medicare Advantage and other programs of Medicare, and to the extent that private health plans look to this model as well for payment, they multiply by what's called a county payment amounts for the county in which the patient beneficiary is residing, to multiply that out to create a monthly payment, and then that, of course, projects to an annual payment for that patient or beneficiary. County rates are developed around the country and come out of the Medicare database, and they're based on prior year A and B costs trended forward, or the average per capita fee-for-service payment amounts in an area. Payment rates, and this is just using a 2011-2012 example, and these are also posted to the CMS site. Payment rates, for various reasons, the cost of medical care in a particular area around the country vary, and you can see that variance in some of these examples on this slide. So how does that the system apply to a particular patient? This patient presentation was used in other presentations of the Academy. So an actual case for you. And here's the story on the right-hand side, and some of the medical history, and also other information about this beneficiary, or patient, excuse me. And you can see that the second from the bottom, the Medicare risk score is 4.6, and you can also see what personal goal was. Again, describing that diagnostic, showing that diagnostic codes, some get risk adjusted and others do not. On the left-hand side, these were the diagnostic codes for our patient here, and which ones made themselves over to the HCC, get risk adjusted into the HCC system that was in place at that point in time. So kind of the roll-up for this patient shows the risk-adjusted factors, the frailty factors, the demographic factors that were scored in the prior page. And you see underlined the HCC risk score, and again the additive nature of the formula above, producing a number of an HCC score here of the 2.236, and then there's a coding intensity that occurred. So the risk adjustment and multiplied by this frailty adjuster, and the payment rate, that county payment rate in that area of $845 at the time, produces a monthly payment to a Medicare Advantage plan in this situation, but it could also be a practice in the future or a targeted expected expenditure for that patient in the future, and in a sense what would have created a virtual or budgeted expected for you in your practice of nearly $1,900 per month. So somewhere in the low $20,000 would be expected to be spent for the future medical expense of this patient. So why is medical record documentation important for risk adjustment? As we see the risk adjustment payment methodology in place with Medicare, it relies on complete medical record documentation and diagnostic coding. As we see, the specificity in diagnostic coding contributes to risk adjustment. And generally the case, the greater the diagnostic coding specificity, the more likely that a code becomes risk adjusted. Also to note that CMS conducts risk adjustment data validation through medical record review. They do this with health plans, and one could expect that this would drill down to the practice levels that are paid on this basis in the future, and also by private health plans through relationship with your practices. And again, the specificity of the ICD-9 diagnostic coding is supported and substantiated by the medical record that you produce. An aspect of this is reflected in this comment of a health plan advisor or consultant, if you will, who is recognizing both the value of good chart documentation and the impact on HCC scoring and payments to health plans, and also the value of house calls at the same time. So as you know, and as we know, and this figure was used of the 6% or so of Medicare Advantage members who are homebound or institutionalized tend to be sicker than average. And then at the same time, the clinical coding and the documentation for these members tends to be poorer than average. So it seems that the coding and the documentation that occurs in the inpatient environment or even in other ambulatory facilities is stronger because that's feeding into different payment models as well. So it continues that this combination means that a comprehensive history and physical exam along with good documentation for the 6% of members represents up to 40% of the coding opportunity, meaning that an improvement in the documentation and again that specificity would produce an overproportional improvement in HCC scoring and result in payment to that health plan. And also added that in addition to being the most likely segment in which potential hospitalizations can be averted with a physician visit or other clinician visit, which is what you know and what your good services are providing each and every day. And then here in the bottom point was just to provide what that would mean in terms of payment levels, and then also what the averted hospitalization would add to the benefit of that health plan. This also reflects that some of you may be involved with assessments with health plans or seeing the opportunities to provide assessments to health plans, and this provides some evidence of why those are so desired. And CMS is looking at those in addition to the idea that they are feeding into the Medicare Advantage health plan payment system. They also want to make sure in future years through policy development that they feed into ongoing medical care of the Medicare beneficiaries. CMS does have audit systems into place for HCC documentation and the coding, and again they want to make sure that that documentation and coding and those HCC scores are indeed substantiated by the medical record. So they review medical records of the Medicare Advantage organizations and also of the PACE organizations, and that can be expected to filter down over time as well. And you can see the methodology here. And prior validation audits have found that 30% of records that the coded conditions are not supported by the documentation, and 30% of the records reviewed. And the name of the program is the Risk Adjustment Data Validation Program. and that's what they have in place for to audit the medical records. And there is a link here or a citation to the CMS site that would provide that provides information about that process. And that's just a few-page document there. Okay, so where to find the ICD-9 guidelines? And hopefully you have these both from an electronic version or also to the extent still existing in paper. But you can also find those on the CMS site. Here is a link, and this is the last version that was updated. Again, there was the idea that ICD-10 would come into place, but an ICD-10 would also flow into the HCC scoring methodology. So here is a link to the ICD-9 guidelines, and again, there are thousands of codes. We can't review each and every one of those on the phone today or another day, but we can provide some guidelines and tips and also references. So here are, this is the 107-page of the guidelines to the thousands of diagnostic codes, again, organized by disease.